Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey that works with us at Safe Pet Anesthesia. And I'm Dr. Gianluca Bini, CEO and co-founder of Safe Pet Anesthesia, a training and teleconsulting company. And I'm also an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, guys. So tonight it's Tasha's turn and picking the topic. What's going to be, Tasha?
You know, I went back and forth about this for a bit, and originally I was going to really stick it to you guys, and we were going to talk about physics and the various, all the various. I know, that's why I was like, we should study. But I felt like we actually should study if we talk about that, because I was going to be like, let's talk gas laws, let's talk Venturi, let's talk Bernoulli, let's talk Laplace, and talk about why all that very seemingly theoretical stuff is clinically relevant. But then I thought that would be a cheap shot without any warning. So instead tonight we're going to play a game because it's Halloween week. We actually, foolishly, we should have worn costumes. Anyway, I'm kind of dressed up like a lumberjack elf. But anyway, besides the point. Also, I do want to show you this. Look, I'm making little tangerine jack-o'-lanterns.
I mean, I've got something here,
Cute.
The only one that doesn't have anything Halloween related here.
All right, you have two cute golden retrievers. But anyway, so instead of tonight, we're going to play a game. We're going to play Never Have I Ever.
Oh, God.
The anesthesia version.
Oh, God.
Do you know how to play Never Have I Ever?
I need
okay, so what one person says never have I ever, and then follows it with a statement, and then whoever has done it has to admit to it and then provide the relevant anecdote. So for example, this will be an anesthesia version. I don't know what you guys do in your weird personal lives, but yeah, so I thought I would start with, and it's kind of a fun way to talk about stuff that's maybe a little bit more controversial, maybe help dispel some of those, hardcore anesthesia urban legends. But I'm going to start tonight with never have I ever masked a patient down.
So this is the moment. If I understand correctly, this is the moment where.
And this is excluding exotics, Bailey, before I get that.
Oh, okay. I was like, well, I've definitely done it. I've got numerous stories of how I have masked.
No, never have I ever masked a cat or a dog down. Let's say that.
A cat or a dog. I got to think
that for research.
Yeah. I was going to say, what about box induction?
Yeah, we'll count a box induction as a mask down because it's really just a big mask.
What if it was a rabbit?
We can use a rabbit.
What if it was for research? What if it was for a math study?
Wow, this game's turning sour quickly.
Yeah. Backfired so hard.
No, just never have I ever in normal everyday practice, either when we were GPs or what have you masked a patient down outside of research, outside of exotics, where, for example, like today I was involved with a tamandua and you cannot intubate those. So fair enough.
Yeah, I was going to say, I'm sure that was impossible. And you're talking in our anesthesia careers.
Veterinary careers.
Well, then for sure. For sure. As an assistant, I am sure I was involved in box inductions for mean cats back in the
1900s
when I first got my job in as a lowly assistant, cleaning up the kennels and scooping shit and painting the back hallways and all the little gopher jobs I had to do.
Did you start as an ACA, like an attendant, like an animal care attendant?
Yeah, for sure.
I started as a receptionist.
That was my first high school job, was in the back, holding, restraining, watching cat. We had a cat that was where I worked, we did they started as a mobile service. So they bought an ambulance from a local fire station that was decommissioning it. And so they used to go do house calls. That was their main business. And then they got a standalone practice. And that's when I joined them shortly after that. And, so they still used to go to clients' houses and pick up their pets and bring them. So one time I had to go pick up this feral cat. It I was like, guys, just, this cat's like super feral. It was like bouncing between the windows when I was going to like try and grab it with a quilt and shove it into this carrier. It was a mess. And then I was like, just this cat's feral. They like opened it up, and the cat like a Jack in the Box, just like boom, like into the air, and he's like all over the clinic. He like ran under the X-ray table for a while. He like got into the bathroom, and we had to like catch him with a trash can. I think that cat ended up going home without anything that day because it was too much of a mess.
Did you box that cat down?
We did. I think we decided after all the commotion that we were not going to box that particular cat down, but there were definitely animals that got boxed down at that clinic.
So, question really then, in terms of those kinds of...
No, I have a question first.
Okay,
You
is this
said
about the
the 90s. You said the 90s, right?
I guess, yeah, well, let me think. Yeah.
How old are you?
I mean, I started working when I was 14. So, like, this was in high school for sure, and I graduated high school in 2002. So it's almost assured that there were some, like, maybe 1999, maybe 2000. So,
Wow.
yeah.
Turn of the century, we'll call it.
I mean, it was like walking distance from where I live, so I could walk to work.
Well, you would have had to, because at 14 you weren't driving.
Well, I had a family with a car. I also had a bike. Wasn't like...
Back to the boxing down. Beanie, have you done this?
In my veterinary career, if we exclude research, I've never masked down an animal.
Not even like a hamster?
No.
I was actually just advising someone on masking down a gorilla.
That's solid. How would that go?
You give them a heavy IM pre-med, and then what I remember,
Why?
my mentor, well, for safety. So what my mentor did was he would get an LMA, and because gorillas' faces are kind of flat, if I remember correctly, he would place the LMA on their nose until they had breathed enough. He used SIBO in these cases most of the time, until they breathed enough SIBO that they became sleepy enough that you could then stick the LMA into their airway and kind of finish off the induction and then reach for the endotracheal tube. So you didn't have to get venous access right away. Yeah.
Okay. Interesting.
I just want to add in, it is not uncommon to induce children through a mask induction.
Yeah.
They use SIBO because it's a little bit more pleasant, I think, on the airways and whatever. And like, you can tell a child to take a deep breath, but honestly, the ones I saw were like really little and they were just screaming. In a patient, I mean, they were like babies. Like, this was when I was doing my pediatric rotation, and I was like, I'm not coming back here for sure. I don't like this.
Certainly not bringing my children.
Yeah. So I think there are situations where, like, with a heavy ion pre-med, a box or mask induction is not the end of the world in the right situation. But I do think there are a litany of other options that we should probably pursue. I think dealing with the patients that I deal with, yeah, it's not going to happen. But
you can mask down some of the clients. That would really make my life easier.
But I think it's just not going to happen with my patient population. But like, if you're dealing with like the young healthy dogs for spays and neuters and stuff, like, that is a different population.
And I think, to be honest with you, I mean, it's not pleasant for the animal, right? Like,
I agree.
Let's put this out there. Like, it's not pleasant for the animal. Oftentimes, it's done in places to the contrary to what Ryan is saying. It's done in places where they don't give an IM pre-med. The cats are fully awake, or the animals are fully awake. Some people are less skilled than others, right? And so, it's not done in a safe manner.
There's a mask sedation or a mask induction because, for example, you might have limited resources or staffing, or you've actually gone through the textbook and you're like, oh my God, like what, like literally what is next?
Mm-hmm.
As opposed to, I can't be bothered to modernize my practice or like to make the effort to make some considerate decisions, like Ryan said, oral pre-meds or IM, what have you. But yeah, no, I was just wondering because, I mean, it's still technically like a technique in the box. And I know it has its disadvantages. And
No pun intended. in the
I
box.
never ever use a double entendre. And entendre for the French Canadians was a dongamet. But anyway, yes, no, I was just, curious to see. I suspected that both of you probably don't use this as like your first line, but it used to be such a strong anti-sentiment. I was actually more interested to see whether you would land maybe a little bit more towards the middle, which you did, than perhaps we might have 10 years ago. So that was really my question there.
I will say, I think I like, I'm trying to figure out how to phrase this correctly, but like, I just think there
Because
is
this is the episode where we're going to start being politically correct.
there is a
Oh, okay.
reliance in certain situations on a box induction where like we could combine drugs to make the box induction better for the patient because like the box is very stressful. Like they're often trapped in there. They go through a hyperexcitable phase in the light plane of anesthesia, which, for the record, we see all day, every day with people pushing propofol where they don't push enough and the animal starts to get light. And then you're like, now slam it in because you push too little or you push it too slow because you're nervous. So, like, it's not to say, like, the hyperexcitability we see both with IV and box induction. So like, I'm not sure I can buy the argument of like, well, it's worse for them, but you have the immediate solution in your hand with the injectable technique that you can like make up for those patients who are developing that. Where the excitable phase in those box inductions, you're then like their minute ventilation gets all out of whack, and then maybe they're taking big deep breaths and you're going to get lucky and they go down fast. Maybe they start taking short shallow breaths because they're panting because they're so scared, and then their induction takes longer and longer and longer, and everything gets worse and worse and worse. So it's like, I feel like using an IM pre-med in those situations would probably make that, I just wonder if it would make it a more equivalent induction. And it's just like out of like just like simplicity and not keeping up a little bit that people are not using IM pre-meds for those. I mean, in some of those cases are probably not ones where we're going to get them, but I just feel like there's so many patients we can get at least a little IM pre-med in them.
Yeah, I
Yeah.
agree. I
I don't know.
think
That's my little
unless
soapbox.
it's a ton of an animal who will kill you,
Yeah.
and you don't have capacity for like remote sedation.
Yeah. But you also
I
can't mask
struggle to
that
think in
behind.
our day-to-day dog and cat situation, even horses and what have you, that you can't get some form of IM in.
I will say, I do want to share an anecdote. I did once try and mask down a patient, and I immediately was like, this is the dumbest decision I've ever made. It was a patient who, through a variety of different circumstances, had bitten his tube in half and ripped out his IV catheter. And
Hooray.
we were in a situation where I could not have a lot of items with me, if you know what I mean. And so I just grabbed a mask and I put it on the circuit and I attached it to the dog's face and cranked up everything to try and get it down. And I was like, this is not working. I need something with injection. So ketamine did the trick. Dog went down real smooth after that. And we got the rest
I
of
had
it.
a similar one. We had a wiener dog on the table having like a hemilaminectomy. It was when I was a resident, and so I was circulating between cases and students around the case, and I came back in the room, and like how when you leave an OR and everything's like you got that chill, and then you come back in, and the instant vibe is that there's some catastrophe that's unraveling like while you're just walking
Yes.
over.
Yes.
I got that, and I realized like the dog, I guess, had not just gotten light, but woken up, bit through the tube.
Yep.
It somehow actually extubated the bitten part of the tube, which was a Christmas miracle. And because it was a wiener dog and it had thrashed with it like an exposed spinal cord, it had ripped its own catheter out, right? So now I got a wiener dog with an exposed spine who's extubated and no IV catheter. And I was like, well, right. And the neurologist is looking at me and I'm like, just gonna need a minute. And so that's what I did is right. Like I just cranked isoflurane up. I cranked oxygen flow up. I put it on flow by until the patient, was re-anesthetized. And then I was able to sort of regain control of this catastrophic situation. And then I was informed I was never allowed to leave the OR again. And I was like, yeah, no, I'm not going to.
Yeah.
But yeah, I did. I mean, it is an emergency technique too
Yeah.
for that. Because if you have an open abdomen and open chest or what have you, and you lose control of the airway, and you lose
Yeah, you're
control,
fine.
especially if they're thrashing. Like if they've actually gotten to that light plane where they've gone from movement to actual consciousness, they're going to make the break to escape, and in which case they will pull their line, they will extubate themselves, and then you're really scraping shit off the ceiling at that point. So, just for the listeners, like a high fast flow volume of an inhalant will bring the patient back down, as opposed to trying to like, let's see if we can hit an IV in something that's moving, or like IM poke it, which won't be fast enough, or can you get a jugular draw? And I'm like,
Oh
can
my
you
God.
get a jugular draw? Like I haven't recently fallen from heaven, so no. But yeah, anyway, but okay. So that
So
was
for the listeners, the trick is
it.
not let them wake up.
For the record, I was not actually on the case. I was supervising, and a very junior person was on the case.
Excuses, Ryan.
Yes,
Excuses.
it's a routine thing for me to let my patient just fully extubate itself, pull out its line, and just like shrug, throw
Yeah,
my
I
hands
just feel when
behind
things get a little boring, I really like
my
to
back.
live on that edge of losing my license and being fired. It's a thrill.
Yeah,
Okay, never have I ever, round two. Never have I ever accidentally overdosed a patient, causing harm.
100%. I've done it for sure.
100%,
Causing
I've done it.
harm? No.
And a harm doesn't
Oh yeah.
necessarily mean like mortality, Beanie. Like I once set my fentanyl pump CRI and I missed the decimal place, and so I was getting a 10 times overdose. And I spent like a good 20 minutes being like, why is this patient so bradycardic? Like, I was just like, I don't understand what this dog is doing. And then I was like, again, resident, like 3 o'clock in the morning, like what? And I was like, oh, I am the dumbest person on earth. So I don't necessarily mean that you caused harm as in like fatality, but you may have caused like a morbid complication per se. Never?
We,
You've never done this?
we definitely overdose propofol every time we induce.
Oh my
Okay.
god, that is you are. Oh my god.
Isn't that true though?
Not in Bartel's world, but
I
because
mean,
I
I don't
always
use
my
propofol,
co-induction
so not a
agent.
problem in my world.
I
oh,
have my
listen,
nice
I just
90
mask them
second
all
co-induction
down.
agent window. I exercise patience during the induction of anesthesia. Patience for my patients. But
Wow.
you really, Beanie, you've never like
I
mistaken
no,
ketamine
I
for
had
flush, for example.
I had a technician do that. Like she gave 10 times the dose of methadone. Again, decimal place. Now, did anything happen to the patient? If she didn't tell me, I would have never known.
10 times a dose of methadone could still be a regular dose of methadone, depending on your
It's a fair
dosage.
point, Bailey.
Yeah.
That's fair. If it's a Davis dose,
Could be
I
100
mean,
times. Could be 100 times.
I gave a I gave a pug dog like a mig per kg of methadone one time because he needed like an emergency eye surgery, and I didn't want him to yak on some sort of other opioid. It's okay.
so wait. You gave him a make per kg of methadone
Yeah,
to
for
for.
eye sedation for a catheter because he was like screaming and being.
Oh, gotcha.
And
Okay.
being a pug.
It was a little pug with like some sort of ocular emergency.
Don't they make Daxmed in your world?
Well, that could cause them to throw up, Dr. Beanie. So we were not going to use
How
that.
often do you see that?
Often enough, for sure. For sure.
That's a great question, Beanie. How often do we actually see it?
I
If
I
see
you
it.
never see
give
it.
opioid alpha 2 combo in pre-med,
Oh my
Unless I
God.
put hydro in the mix or morphine in the mix with buprenorphine or methadone or fentanyl, I never see it. Like I know it's described and there
Yeah.
is out there. I don't know if it's a dose
I
issue.
haven't had a patient yak on pre-med since I
But
don't
are
know
you giving
when.
them Serenia as well?
No, like
Interesting.
they get it usually at induction or
Yeah.
I don't because at that point I always tell them I was like,
What are you giving it, sub Q or something wild? Like, what are you doing over there?
I don't see it all the time. I saw it like literally today. We had a patient. I don't remember what it was for, but I got dexmedetomidine IM as a pre-med, and I walked by the cage, and there was like a little bit of spit up in the cage, and I was like, "Oh, patient
tip or
vomited."
not? Like is it saliva or is it like
No, it was like food tinged, like I don't know. I mean,
But you're not
assuming the
seeing like the
patient,
full, like the old hydro pre-med that you use, like hydro ace that you used to see
yeah.
when you did the
I
and then they
mean, it
like would
wasn't like
evacuate
that.
you and jejunum forward. Like you're not
No,
seeing
like there's a variety of throwing up, Bartel. You can definitely attest to this, especially with your recent
that. Okay,
incidents.
rude.
You should understand all the litany of throw up. I mean, we in America have like probably like a few words like vomit, throw up, whatever. But like I'm sure there's some place where they have like 27 words for throw up, like the Inuit people have for snow or whatever.
Don't drag Canadians into this conversation. No, I just, like back, if you've used morphine, even if you've used oxymorphone, if you've used hydromorphone, and I still remember like sub Q is a pretty common thing when I first started this shtick too. And like
I hate
almost
you.
every patient at that point would hurl, right?
Yeah.
Like, and like, I remember when I was in GP, actually, I was going to go neuter this massive doodle called, this was a long time ago. So I would imagine Bruno has since crossed the Rainbow Bridge, but Bruno was just there for a neuter and he vomited from the pre-med and he brought up like 8 pairs of full size, like knee length socks.
Gross.
And because remember, it used to be like an intentional technique to induce vomiting so that you would have an
Oh,
empty stomach.
I have been there.
Yes, I know, because you went to Davis, where they still think that
Yes,
that's a jam.
yes. We did that C-section, and the puppies were very dull. I
But
remember.
you don't see that kind of like that like violent type of
No,
vomiting
no, 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 no,
on
no.
methadone. Certainly, like I don't even think I've ever seen anything vomit on buprenorphine, if like, or
No,
butorphanol.
no.
But yeah, like you don't see that anymore. So that was, I think Beanie and I thought maybe you were seeing like old school hydro barfs with methadone.
No,
And we
no,
were like, what the hell are you doing?
no. Okay, so first of all, I have definitely overdosed a patient. I'll tell you the story. But one question before I do that.
Yeah.
Do you ever see excessive drooling with butorphanol? Someone asked me this the other day, and I was like, I didn't
In
see.
cats, sometimes, yes.
Okay, okay.
Twice I've had seizures induced from IV butorphanol.
Yeah, I gave IV butorphanol to a dog with like a big old brain tumor, and he like did not. It did not. He did
Yeah.
not.
Also,
I get a
FYI,
seizure on almost every drug that I can name, to be honest. Like that's always my thing where I'm like, if you get in there and you disrupt brainwave activity and like they have something underlying or
Yeah.
untreated, you're going to see it. But
yeah. Yeah, butorphanol definitely, I've seen it in cats for sure.
Interesting. Yeah, this was a cat, and I was like, not something I really think about a lot, but I would still not hesitate to use it. And I don't know.
I don't use a lot of Torb,
Yeah,
but if I do, I've
right.
seen it in
The right
cats.
procedure, all that kind of stuff.
Yeah.
So, can I tell you my story about overdosing a patient? Because
Go
it's
for
a
it.
it's a doozy. So it was back in
he's so
residency.
excited to tell us about the
No,
mistake he made. Like this is
yeah, oh, for
hilarious.
sure. I have thought about it a lot ever since. So it was in residency. We were doing an epidural in like a goat, as you will, and we were doing a morphine
Blocked
only.
goat?
I don't. I'll be honest. I have no idea what the procedure.
Probably.
I'm guessing it was like an abdominal thing. It probably was a block goat, but we did the epidural and we gave morphine. It was a morphine only epidural, and I was handed the drug and I did not double check because like it was pretty routine that when someone handed you the epidural drugs, they were like already like ready to go, and so I didn't double check it and administered the whole thing into the epidural space. That goat had a super intense pruritus, like so.
What was it? But was it the right drug?
It was the right drug. It was like
Oh,
like
okay.
it was a it was all the volume that they had bought for the patient.
Because I remember there was a
Not,
kerfuffle, not directly involving me, but where there was a mix-up between what the syringe for the injectate was for. I think it was either a cow or a horse, and instead of it getting X amount of lidocaine, it got X amount of xylazine,
hell yeah.
and that was a great time for that particular.
Yeah.
Yeah. Mm-hmm.
Yeah, no, this was like, you bought the morphine by the vial and they drew it all up. And so I just like, so I thought
Well,
it was
this
like,
is always thing. Like I was always trained when I was a resident. Like you never should. You know how people will be like, "Well, it's propofol dose is 4 mils, but I'm just going to pull up 10 because I may need
yep,
more."
yep.
And I was always taught to never ever do that because for this exact reason
Yeah.
that some people might make the assumption that what's in the syringe is the dose, and then all of a
Yes.
sudden they're pushing
Yep.
3, 6, 10 times what they should be because they didn't realize they were meant to either aliquot that dose out, or they were
Yep.
meant to titrate accordingly. So I generally don't let the technicians or the team,
Yeah.
the interns do that. I'll ask them to pull a second syringe, so that you don't have someone who doesn't know any better, like all of a sudden give a cat like 10 cc's of propofol, because you're
Yep.
like, oh, thanks for that. I really,
Yep.
whew,
So I'm wondering
stop
if
fixing this.
did all your so these episodes that you guys experienced happen during your residency or afterwards?
This particular one did happen in my residency.
I've seen crazy mistakes when I've been in academic institutions, because you do have a large student population.
Yeah.
But personally, the next question is, never have I ever left the pop-off closed. And I think, yeah, if you haven't left the pop-off closed, you're
You haven't lived.
lying. But yeah, like I think you see a higher percentage in training facilities, also because I think just generally they're bigger population numbers,
Yeah,
so we have
for
to
sure.
normalize the data for that. But I've made some of these fucking dumb mistakes, in the last 11 years of
Yeah.
private practice.
Do you so
Is that a dog lapping?
That dog definitely got dexmedetomidine and he's yakking in the background. I know it. I know it.
Boy, I hope the readers can hear the dogs
yeah.
gagging. Welcome to our podcast.
This is not Chole.
Joel, you're so cute.
Oh, it means hazelnuts in Italian.
I already knew that because I eat a lot of Nutella.
Aw, me too. You know what's the best this time of the year? If you get like panettone and then you cut a slice and you spread Nutella on top.
Ooh.
I mean, it's like it's 3,000 calories right there, but it's so good. It's so good.
Gotta hibernate for winter here.
Yeah, we live up in the North Beanie, where you want to lay some fat down for the cold
Hell
months ahead. Like,
yeah. It's
Till,
coming.
till last week, it was like 90 degrees here.
The weather here turned in like a heartbeat. It was like shorts and a t-shirt, and now it's like frigid. I like have to
you must
think
have
about.
frost on the ground, because we've already switched over to like me scraping my car window from frost in the
No, we
morning.
don't have that yet. We haven't
Hmm.
had frost yet. I'm sure it's coming, but it was I mean,
Glad-
who knows? We had snow a few years ago when
When
on
I grew up, every
Halloween.
Halloween costume I ever had was ruined because I had to wear it with snow
Oh,
pants.
hell yeah. Hell yeah.
Every Halloween costume you either had to wear
Absolutely.
under your winter coat or over your snowsuit. And I was like, this is not how ballerinas dress, Mom.
unless you dress up as an astronaut every time.
Yeah, or a skier. But no, I always wanted to be things like ballerinas and pirates and things that did not align well with snow outfits. And so I would just be like, no, I'm just going to be cold. And then you'd do like two houses and you'd be like, we're going to need that snowsuit.
Yeah.
That's awesome. So the reason I was asking though about whether it was during the residency. So where I did my residency, there was a huge emphasis on like checklists,
Yeah.
like there was a huge emphasis on we all had our own like drug sheet. It was pre-calculated. So I think that a lot of that was taken away. That chance of mistake was taken away there. Like we would have the students calculate the drugs, but we wouldn't use their sheet.
Sure.
We would use our sheet.
Yeah.
Like we and the students weren't really, depending on the institution, some institutions give them more degree of freedom than others. NC State is definitely not one of those that gave them at that time
Yeah.
a lot of degrees of freedom. The technicians or the residents were running the cases and the students were helping, but they weren't pulling up drugs or doing any of that.
I also would like add in that the collective, we have been practicing anesthesia for almost 10 years now. And like there has been, I would say, one of the biggest shifts in anesthesia is towards a culture of safety. And so like everything, like a lot of what we're doing is moving towards safer and safer and safer and safer anesthetic plans. And so there are like things that we are doing from these experiences that have led us to different practices that prevent these kinds of mistakes from happening. So, like I don't, whenever I drop a drug for an epidural, I drop the drugs and I tell people like what they are, like the mils of each and the milligrams of each, and combine them together. And like, I hand a syringe to someone, I say, this is X amount of drug and this is the mils.
Yeah.
And like, so I wonder too if like maybe that's why Beanie hasn't seen it as much as like you and I, because, we're a little older.
Yeah, and like I really
Yeah.
honestly, like I was just like went rogue, really.
Yeah. Yeah.
I mean, 55% of my residency was at night by myself, and I would
I mean,
sometimes have like 7 or 8 cases going at the same time, and I was the only like, it would be me and maybe 2 students trying to get through 7 cases at 3
yeah.
o'clock in the morning, and it would, it would range anything from equine colic to
Mhm.
I once had a V slot on the table that started to bleed out at the same
Yep.
time that the splenectomy was bleeding out. And so
Right.
I'm bouncing between 2 rooms, just like throwing blood at everything. And so it was a lot more rogue and less controlled. But
Yeah.
I mean, it also like, I was thinking about like we also see like relative overdoses with like negative consequences all the time. Like you're giving a pressor and you end up giving a little extra fluid in the line, and the patient becomes wildly tachy for 5 minutes. Their heart rate approaches 300. Their systolic is approaching 200. Like that is a negative consequence, and there are patients who will succumb to that. Unfortunately, it is like,
actually, it was at Davis, one of your resident mates accidentally flushed norepi in.
hell yeah. I just
Like,
did it today, and I was like, no big deal.
and it was so funny because said resident was like, oh my God, Bartel, Bartel, Bartel. And it was actually the first time we achieved normotension. And I was just like, no, this is a win. Like you titrate to effect. Like
Yeah.
I was we did it. And meanwhile it was like a 10 cc flush that like slammed a norepion. And I was like,
Yep.
well, let's see how this goes, and I was expecting like crazy tachyarrhythmias or like, whoa. And and the surgeon to just go wild about like blood
Oh
spreading
my
out and
God.
everything. And anyway, it kind of fixed it. And I was like, that's between you and I. And I was just like, this conversation does not need to go outside of just
Yeah.
you and I. And I was like, don't even sweat it. Like titrate to effect, like high five, like I'm out of here.
Yep.
Yeah.
Yeah.
That was
Yeah.
that was a that was a that was a memorable moment. All right, never have I ever lied to a surgeon just to keep them quiet, and actually really I've done nothing anesthetically.
Literally all the time. My favorite maneuver is they say the patient's getting light, and so I stand up and I put my hand on the vaporizer like I'm doing something. And I stand there for a minute looking concerned, consternated even. Sometimes maybe I like cross my arms and look very serious. Or maybe I like grab the syringes and I like lean on the table a little bit.
I love how you actually like put so much dramatic flair
You
in
put so much effort into this.
Oh yeah, for
Awesome.
sure. And I'm like, is it better now? And they'll say, yeah. It's great. It's great. I'm like, okay, cool, good, thanks. Let me know if it gets bad again.
it. You know
That
what I do
placebo
really?
effect is huge.
Yeah.
I often like I've had like the RVT will call me in, they'll be like, oh, we're really struggling with this, blah, 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 blah. And I'm kind of in my head, I'm like, there's absolutely fucking nothing wrong. It's just somebody is just being real obnoxious. And
Yes.
my favorite thing to do is what I do is I go onto the ECG and I boop it from like lead 2 to 3, and then I give it a couple seconds and I boop it back. And then I do what you do, and I'll be like, how are we doing down there? And they'd be like, no, that's great. That's great. Thank you so much. And then I just say nothing and I just quietly leave the OR. And then I laughed so hard because the technician was like, after this particular case, she was like, Bartel, what did you do? And I was like, oh, nothing. I just booped the monitor and fobbed them off, really. And she just
Yeah.
started to laugh and laugh and laugh. She's like, because she was like, I swear you hadn't done anything. And I thought, man, Bartel is slick. Like she must have done something. And I just like blinked and missed it. And I was like, I did absolutely
It's so fast.
I was like, I did absolutely nothing because like there was nothing to do. Because I have learned the hard way not to listen to surgeons about things like abdominal tension, gut
Yep,
color, like that kind of stuff. So
for
I
sure.
will give them concession, but when it's just like bullshit fussing around because it's like they almost have nothing else to complain about,
Yeah.
I just go in there and I'm like, oh yeah, and then I fool around with like the ECG leads and I make some comments and then I just walk out and I've done nothing.
Yep.
You know?
So this is typical, right? So I think there is some. I was reading, I forgot where, but so somebody actually did a paper on this, where in when I think they recorded the OR and they were looking at like how often like the surgeons ask the anesthesiologist how the patient is doing, right?
Mm.
And the shittier is their procedure going, the more times they ask you how the patient is doing. Like
Oh,
because they are so worried about their procedure, or the patient is not going the way it's supposed to go. Their tendency is to ask how the patient is doing, just to get their mind off of the fact that the procedure isn't going as planned. And so there is some psychology behind this. And so then, yes, that's where the placebo effect comes in, and you're like, okay, yeah, sure, I fixed it, even though there was absolutely nothing to fix. But yeah, I mean, we've all done it, in residency, especially,
yeah.
or yeah, I mean, even as a faculty, you do it, like, you go in and they ask you about it, and there's nothing to actually fix. The patient is doing perfectly fine, and you're just like, oh yeah, is it better? Is it? Yeah, sure.
Like
Yeah,
the
yeah, no,
dog.
you're right. You're right. Yeah, no, yeah, perfect. I've adjusted that a couple things. Let me know how we're doing. I'll check in a
Yeah.
couple minutes. And they're like, no,
Yeah.
it's much, much better. And you're like, amazing.
Or you walk in and the end tidal ISO is at like 1.6. The dog has a block on board, and the surgeon's complaining about something. You're like, what's going on now? And then the thing you do is you turn the vaporizer down. And let's try and take out some of the gas here, guys. Didn't know we were going to send this dog straight to hell.
But so yeah, that's awesome. But a
Dog's just
placebo
staring
effect
at
is
you
good.
like this.
Well, I recently had a surgeon say, like, I think that you guys should run all your anesthesia decisions by me before you actually do anything. And I laughed
How
him
did
off.
that go?
I laughed. You should ask him that question, not me. About as well as you would guess it went. But I
Yeah.
was like, yeah, I was like, I'll get right on that.
I remember a specific moment where you had to run an anesthesia decision by a resident surgeon when you were at Davis, and I remember how well that went. And it was one of many life changing events that occurred in the brief stint you were at Davis, and I was dying.
How did that go? Tell me more about this.
I wanted to do an epidural in a cat who was having a PU,
Mhm.
right? Reasonable. And the first year surgery resident, aka twat face, came in and was like, "No, you're not allowed to do that." And I was like, "Who the fuck is this kid?" And I was like, "Oh, sorry, how long have you been a vet? 5 minutes?" And I was like, "Yeah, no, I'm board certified, and I don't need your permission." So they left, and they came back, and they had their attending, and I was like, "Oh, this is upregulating fast," and I'm confrontational, so I was like, "Here we go." Anyway, and so they sat down, and then I was like, and they were like, "Well, we just have these concerns and blah blah blah." And I said, "Well, tell me through your concerns." Well, we don't want it to have urinary retention. And I said, well, it's not really the epidural. And I sort of explained that it's not the process of the epidural. And sideways also had to make a couple notes on the innervation of the bladder. And then I also said that I was going to use a buprenorphine based protocol, and that buprenorphine has not been correlated with urinary retention. And then I think I landed it with, really, if you don't know what you're talking about, you should stay the fuck out of my induction area. But I was like, there is zero chance in this lifetime that I'm going to ask permission from a resident in a different specialty to do what I think is best for a patient anesthetically, which was actually a real culture shift at Davis, because back in those days, like even like the 30-year, like tenured ones were like, well, we should ask surgery if we can do the block. And I was like, I'd rather swallow glass. Like, I was like, I'm absolutely not going to do this, which I think, to Bailey's point, was the first time he'd ever seen an anesthesiologist push back, and really sort of draw that line in the sand, which has really been like the
I mean,
team.
maybe push back so forcefully, like so directly and so intensely, which is like more my confrontation style. I tend not to be a like beat around the bush.
I'm what people sometimes refer to as a type B Canadian.
So is the type A Canadian the nice ones, and you're
Most Canadians are fall into that type A, like jolly, apologetic, don't appreciate confrontation. But I've been called a type B Canadian, so there you go.
Yeah,
I
sometimes
should have been a hockey defenseman. That's really should have my life should have gone. So
that's awesome.
people say I speak too directly sometimes because I'm like, let's not. You don't need to say hello. You have a question for me. Please just direct your question at me and I will answer it. Like there's no need to exchange pleasantries here. Let's just like get on with it.
you're definitely getting crankier in your middle age, Bailey. That's for sure.
I've always been cranky, let's be honest.
Fair point.
I just was a trainee, so I got to have fun. Now I'm no longer a trainee and I have to, crack the whip. My time is money, man.
Okay, Linda Evangelista, you don't get off the sofa for less than 10 grand.
Okay, right.
All right, last never have I ever. Never have I ever panicked because I genuinely felt like I was losing the patient and I didn't know what was going on.
Ooh. I mean, I don't know about panicked, but there's been plenty of situations where I'm like, okay, this could be a variety of things, and I'm not 100% sure which one of this is. Right. I mean, and of course, you go through your list usually, right? Like, I mean, some of it's sometimes it's fucking crazy. Like, we had this dog at, I think it was Ohio State, 7-year-old. Nobody has ever heard a murmur on this dog. Been at the vet regularly, been seen at Ohio State regularly too. And we anesthetized this dog, and without any reason, it's hypoxemic. And I was like, okay. So we go through, our list of, 5 causes of hypoxemia, blah, blah, blah. And then at the end, I was like, okay, just let's grab cardio. And turns out that this dog had fucking VSD.
I was about to say massive shunt, right?
Yeah.
And nobody has fucking heard it for 7 years. And,
It's because when the defect is so big, there's no more turbulence. This happened to the dog who had DCM. Its DCM was so advanced that it didn't generate turbulent flow because it just quivered. Crazy. And I didn't realize this, and I gave it a whole whack ton of dexmedetomidine because it was also bananas. In my defense, it did fine. Did fine.
Yeah, I mean, and we fixed it. But we started Norebi and, whatever. But holy shit, right? So there is plenty of moments where you're like, okay, I'm not sure which one of this it is, but we go through the list and we figure it out. So I don't know if panic is the right word, but definitely situations where
maybe not panic, but that feeling where you feel like I don't know if I'm going to vomit or pee my pants. That kind of vibe.
I guess so.
I mean, I've had the pop off left closed. And had a tension pneumothorax from a rupture and an arrest from it.
Yeah,
and
it's weird though. Usually they die
back, but
they usually die before that. They die before the barrel trauma.
They die before the rupture because of the impeded cardiac return.
I mean, unless it's a vein or whatever.
Yeah, I mean, I've left my pop off closed, and I've been lucky enough that I've caught it before.
This one I was not standing there. I was called into the OR.
That's right. The cases where I've seen it really go worst case scenario has been where I'm in the supervisory capacity because I happen to have a personal fixation with the pop off where whereas you like to hang your hand on the vaporizer, I actually usually hang mine on the pop off so that nobody else can fool around with it and not, it's open all the time or it's closed because I'm on a vent or whatever.
We have safety ones now, but
we do too. But even still, you'll actually see me hang out. That's where I kind of rest my hand. Just for sure. I hook my wrist around the pop off. So
I do the same thing.
It's a personal tactic to avoid the mistake of the accidental closure.
Yeah, for sure.
Yeah. I like the pop off. Just that one always makes my internal sphincters clench quite badly. So
yeah. I mean, and again, we cut all of this out, but I think that nowadays every single practice should get one of the new machines with like like the Veda 5 or whatnot. They're
Or the
so much
selection.
fucking safer because the huge risk, and these people don't fucking understand, is like when you come off the ventilator,
Yep.
right? You disconnect the fucking allowel,
That's exactly what
you,
happened. Is
you
someone
put the bag on, you forget
broken
the
the
screw
machine
pop.
down,
Yeah, yeah.
and no one had checked it.
But I mean, it sucks. But
Sure.
I think we've allowed shitty ass equipment in VetMed
Oh,
for
it's insane.
way too long,
It's insane.
way too long. You know, actually,
Oh, okay. I've got one. I've got one I can talk about where I did panic and I did almost shit my pants, and and it's like one I can talk about because there was no disaster struck, but it felt like disaster could strike. So I just felt like that story should be shared, but like, gosh, it just feels like, does it create
I
a
agree
potential
with you.
problem? You know what I'm saying? Does that make
Yeah,
sense?
I agree with you. No, I agree with you.
What
It's
about you, Martel?
Oh, I've had a couple ones, although most of them have been the surgeon's fault. I mean,
No, I mean about what I was saying about
oh,
the story I was trying to tell.
no, I think the story is saying like, yeah, the pop off closed and the patient arrested and we weren't able to resuscitate is reasonable. I think that
Yeah,
that's happened to a lot of us in this particular specialty, whether directly or indirectly. I mean,
yeah,
the reason that the pop off is the fastest way to kill a patient on the machine is this is why, right? And
yeah,
like I always teach it, like, that and the O2 flush valve
yeah,
are and failure to recognize you haven't intubated are it's like the triumvirate of arrest. So it happens. I think you could enact every possible safety measure
right,
known to humankind, and unless you have human error removed from the circumstance entirely, you are still going to see it.
yeah,
And I think that knowing how to recognize it and to address it is still important. And I think knowing too that sometimes we do lose patients despite best efforts, and
yeah,
that's not
sure,
something we should shirk from or hide away from, right?
yeah,
Like you can do everything wrong and the patient can live, and
yep,
you can do everything perfectly and it can still absolutely die. And I think, we need to understand that from the point of view of mitigating blame, shame, and guilt.
right,
So
yeah,
I have no issue with that. But like I've had a lot of moments before where I've literally been like, oh, I go from a very tight sphincter state to a very loose one very quickly. But in particular, I remember I was auto transfusing a cat who was a polytrauma, and it was a hemoabdomen, and we're in there, and like, I've already put like I don't even know like half this cat's circulating volume back in it, and the surgeon says actually the kidney's been rented off, and so it's a uroabdomen, and I've been putting urine back in this goddamn cat, right into its vascular space.
ooh,
Um, and the cat lived, and I don't
oh
really
yeah,
understand why, and
cats are weird.
I don't understand anything about that case.
Study has renal failure though.
But yeah, like that was the kind where it's like my heart sank into my colon,
Yeah,
and then everything below that kind of what got loosey goosey, and I was like, oh shit, like I don't even know. You don't in that moment don't have time to consider like the nuance of the physiology.
right,
Like, what have I actually done? Like, am I gonna have a vasculitis? Am I gonna cause like
right,
an arrest? Like, and a fucking cat lived. Like, thank God,
classic.
because I felt like such a weenus. But I mean, other things too.
I
Like,
mean, it wasn't your fault. You did it now.
it wasn't my fault, and it wasn't really anybody's fault. But I was like, I kind of was like, shit. Like, what do you do? Like, what do you do when you've infused 100 mils of urine into a cat's vascular? I don't fucking know.
It
And then,
didn't look like urine, I hope.
yeah, and then and I was like, what I actually did is my only other recourse because the cat continued to bleed, and of course I'd put in a whole bunch of contaminated garbage into it, so I had to give it dog blood. So we are just going from bad to worse. Like it was just such a cluster. But anyway, it lived. Not my finest hour, but I've also had other things like a very skilled and very experienced surgeon that I respect was basically doing like a staff pet OVH, like spay. And when he went to ligate like the body of the uterus at the like top of the cervix, whoosh, right through all the uterine vessels, and the cat's just bleeding out. And he looks
Oh,
at me and he went, well, this is going to die. And I was like, oh, not today, Satan. So I was like, you put your finger in the hole in that dam until you figure out what you're going to do about it. And in the meantime, I'm going to go get some more blood. But that, I actually, because it was a staff pet and because you weren't anticipating that at all, like healthy cat, straightforward spay, board certified 30-year surgeon, me. So of course it almost died. And
Right.
I was just like, that was definitely another one where I was like, I think I just tinkled in my pants a bit. So,
It's always a staff pet.
it's always a staff pet. I've
Oh,
I
stopped
mean,
agreeing to do them. They're like, Tasha, and I'll be like, oh, no, I'm definitely, I'm going to be sick that day. Like, I just,
refer them out.
I
yeah.
think
Like,
the big things I've had where I've like felt like I'm gonna crap my pants is where the equipment is either not where it needs to be, or you don't have all the little bells and whistles that we think about. So like I had a patient, it was an endoscopy. It was a relatively straightforward case, patient had pulmonary hypertension, which is like usually a nothing burger. But I chose a plan that was like cardio safe and this and that. And we induced anesthesia and the dog immediately just like desaturated, like in front of my eyes, like purple as the night. And I had nothing. Like I just had the anesthesia machine in my hands.
Yep.
And I was like, what
I had one of my mentors during my residency. I remember it clearly for very first case with pulmonary hypertension, and she was like, "These are the ones that die."
Yep.
Period. Which was like everything else you can play with. These are the ones that die. I was like, cool, and that stuck to my brain so hard. Now, every time we have a case with that, like I straight up call the vets and like, hey,
Yep.
to be, the owner needs to be aware
Yep.
these die.
Yep.
So, it could go well, but maybe not. So,
After
we should
after
write a
the initial,
blog on like the top, like, because you always have like a mentor or somebody will just say something and it's almost like it's tattooed on you, right? Like
yeah,
I just remember, like, just like you say, like pulmonary hypertension, these ones die. One of my chiefs at Cornell said to me once, they're like, liver lobectomies, they only go two ways. They either go fine or they go shit.
yeah,
Right. And like there's no, it's not like, an enterotomy where you can be like, oh, it's a little septic, so it's a little rock and roll, but you kind of like pull it back up and everything looks great at the end. No. Liver lobectomies, you either it's fine or you're dead. And like that was also like that because like, my text will be like, oh, it's a liver, we're gonna do a lobectomy. And I'm like, second catheter. And they're like, everyone. And I'm like, everyone. And because when it goes shit fast.
mhm.
And it's usually going to be hemorrhagic. And I'm just like, you know what? And like, that's one of those like mentory things that got said. And I'm like, I'm just not going to budge on this. We're just second cathetering liver lobectomies. Like, that's just the way it is for me.
I mean, like for me, it's like cat pancreas surgery. It's like you touch that cat's pancreas, and their pressures will just bottom out, and there's nothing you can do. You just have to pray they survive, and like get the epi, get the norepi, push everything you got, and like just hope, and like fingers crossed.
yeah.
Yeah. I think for this PH dog though, I did get to use my brain and I fucking made a PEEP valve with a bucket of water and the exhaust hose. And I got his sats up, but we woke the dog up because we were not equipped to deal with that situation. And
Well,
like
those were all
Doesn't
the right
sound like
decisions.
it at all.
Those were all the right decisions. So you did a great job.
yeah.
It's not
Well,
like
no,
me over here giving urine and dog blood to a cat. Like, what's happening,
Yeah.
Bartel? What are
we
you doing?
we had a student. I mean, not we anesthesia, but like one of the vet schools I worked at that gave Go Lightly
Oh yeah.
enema prep
Yep.
IV?
IV.
We had that in my
I've seen that.
we had that as well. And that patient had to come back in for different procedures and we had to like re-anesthetize it. So I remember reading through the record and being like, the patient's potassium was or sodium was like infinity at one point. Like, what happened? And then I started like digging into it. I was like, oh, it got the Go Lightly IV. I see.
It's also amazing too. Like sometimes shit like happens.
They live. They live.
I
I'm
know
like,
that's the thing. Like I said, you can do really dumb stuff and they live. And also too, like there's some stuff that sometimes has happened where I'm like, and someone looks at you with that like look of like, what should we do? And in your head, you're like, just pretend you know what you're doing. But in yourself, I'm like, I have no idea. I had a tech once flush 10 cc's of ketamine into the IV line of a Shih Tzu's, like it's art line. Sorry, it's art line.
Oh yeah.
Right. And she was like, oh my God, oh my God, oh my God, oh my God. And I was like, we're gonna just see what happens because
Yeah.
I haven't. Right? And I was like, what am I going to do? Right. And I was like, we're just going to give this a minute just to play itself out because like I
Yeah.
have no idea of like, there's not something you can jump in. Like I can't go in and give an antagonist and like, like it's in there. It's been circulated. Like this is happening. And I was just like, what? Yeah, no, I think, and it was fine.
Probably the patient was totally fine.
It was very deep on an anesthetic plane. So we were really able to back off on our MAC value.
Big MAC reduction. Big time.
Big MAC reduction. I find, yeah, when you give, you know, 1,000 milligrams of ketamine to a Shih Tzu, they really lie still for a bit.
Jesus.
But I was totally like, in my head, I'm like, well, what happens if we give it arterially? Like, I guess it goes to the capillary bed and back into the venous circulation. And
Its foot probably fell off, but that didn't happen for a while.
it did not fall off within my known time frame of dealing with that pet. So, yeah, no, but sometimes that happens too, where something happens where you're just like,
Yeah.
what am I going to do right now?
Yeah.
And the answer is, I'm going to do a whole lot of nothing and try not to panic until we figure out what's actually going to happen.
Yeah, for sure.
That's awesome.
Yeah, I'm like, I don't fucking know.
Well, I mean, yeah.
That's it. That's the Never Have I Ever game.
Yay.
Hey, happy Halloween.
What an experience to discuss.
It felt more like a therapy session.
Well, that's okay too, right? Because I think if people hear us and normally we're, really extroverted and confident, and for us to be like, I don't know what the fuck I'm doing, and we fuck up all the time, I think that's also part of it's a good thing to do, right?
Yeah.
Yeah. I mean, we're all humans in the end, right? Like, I wish I was like,
I wish I were PJP.
I've been, to be honest with you, if BJP was here, it would tell you that sometimes he fucks up too.
I mean, I can tell you
He does.
sometimes I saw one time where he made a mistake. He was helping me in dentistry place an arterial catheter, and he got it in, and it was a small little like Chihuahua rat dog kind of thing, and he liked to use his little hemostats to like grip it and put the tape on. And he did that, and I think he was like gripping it and putting on the T set, and he twisted it, and the catheter just went across the room. And I was like, so I guess we won't do this one with an art line, huh? And he goes, no, I don't think so. And I was like, okay, thanks.
Thanks for your help. Okay, bye.
I'd already messed up the other leg, let's be honest. So he was trying to save me, and I was like, ooh.
Yeah, thanks. Yeah, sometimes my technicians are like, you're not actually helping right now, Bartel. And I'll be like, yeah, I know. It's like 50% helpful at best. I'll just go.
Yeah.
Holy shit.
Yeah, I'll just go.
That's amazing. No, I mean, it's normal, right? We're all humans. We're all practicing medicine, right? I will not actually like, this isn't math. This isn't 1 + 1 = 2. This is, and a lot
There's
of
too
patients.
many things happening at a level that we don't understand and can't monitor or even interpret for us.
To be honest with you, there is a lot of shit that, a few years ago we didn't even know, right? Glycocalyx, 2016, right? Like this isn't like something that, we knew beforehand. How many fucking patients got 10 ml per kg per hour of fucking fluids? How many patients got
Oh my God, yeah.
bolused into oblivion, right? Like this is like, we didn't know about it, right? Like, but a lot of it is also that a lot of patients don't fucking read the textbook.
Yeah.
Especially cats.
I heard a story recently where someone gave a patient like a 2 kilo dog like a 200 ml bolus.
fuck me.
over like a minute. And somehow
Cool.
dog was
I hope
alive.
it had
Dog survived.
functioning kidneys.
Yeah, and the PCV of like 5. But yeah.
I mean, his microvascular circulation, I bet, was hella good. That blood was like probably whipping around.
Oh yeah, he was peripherally oxygenating like he was a fucking alpaca in Peru. Like, no problem. Fuck.
Oh my god.
Jesus Christ.
Wow.
Holy shit.
Realizing all this like high stress anesthesia questions about like when did you fuck up, I have failed somehow to discuss hot dogs. So
This is our first hot dog free episode until this moment.
no, we're talking about hot dogs right now.
So,
I'm
did
bringing
you
them up. I went camping recently and I had some fucking good hot dogs because that's
did
our
you
go-to camping snack now.
did you ever fuck up your old dog?
Yeah, for sure. I mean, grilling a hot dog is a bit of an art. You don't want it, you want a little bit of char, but you don't want to like burn the shit out of it and like blacken it to hell. Like you hate it because, it's
Have you ever
always
done the milk carton cooking of a hot
what?
dog?
What?
Cook it with a milk carton?
No, I don't know what you're talking about.
Were you not like a Boy Scout or a
No, I was not. I was
take the hot dog, wrap it in foil, right? You can take a couple hot dogs, whatever. Put it in like a small milk carton, light the carton on fire,
Okay.
like in the campfire pit. As it burns down, it slowly, gently chars the hot dog in the foil, ready to eat.
I mean, a hot dog is already ready to eat if you think about it,
You want to put that nice
I
flavor
mean,
on it and you want to heat it up.
I ate some cold hot dogs growing up. I'm not afraid to tell about it.
Really, this is why people listen to the podcast and they're like, "Are you actually friends with the hot dog guy?"
Yeah. Um,
And I'm like,
You know,
"Yeah,
I
I'm
think I'm interested
actually
in
friends
finding-
with the hot dog guy."
so we, one of our clinics called Ryan Dr. Hot Dog. So that was awesome.
I have a hot dog scrub cap that was given to me by one of my anesthesia friends.
Listen, Bailey, I think you should pick
Mentee
your two
post-residency.
favorite Chicago hot dog companies, reach out to them, say we are seeking sponsorship, have Beanie like generate some sort of like clip montage of all our hot dog conversations.
Yeah.
And we'll wear their hats. Like I
Oh,
will
I
sell
know.
my soul. I don't even care. Let's get on top of this. Like hot dogs bringing, whatever, Schneider's hot dogs bringing you
Vienna beef.
veterinary anesthesia.
Vienna beef.
Vienna.
I've been thinking a lot about what I'm going to do when I decide to leave veterinary medicine. And I think there's a thing called Hot Dog U, where you get to go to the Vienna beef factory and you learn about selling hot dogs. And maybe I'll open my own hot dog cart.
I feel like you would be so happy.
I mean, I'd be a lot happier than
You'd
doing
also
it.
be that weird person that when a normal person just wants to buy a fucking hot dog and you start going off on a hot dog tangent and they're like, oh God, I just want to buy my hot dog and get away.
I think that's how we are when someone asks us an anesthesia question. We're like, let me tell you about the microvascular circulation. Like okay, let's talk alveoli. Let's work through the 5 different causes of hypoxemia.